In this third video, I will discuss the appropriate use of benzodiazepines, including their indications and optimal selection. When considering the first-line indications for prescribing benzodiazepines, there are several. Benzodiazepines are first line for managing withdrawal from benzodiazepines as well as from alcohol. They are indicated for treating status epilepticus, crisis anxiety without psychotic features, for seizure anesthesia. They're first-line treatment in certain acute movement disorders such as stiff person syndrome, specific pain conditions such as burning mouth syndrome, catatonia, and status dystonicus. They're used for REM sleep behavior disorder, as well as in end-of-life palliative care. While those are the first-line indications for benzodiazepines, they are more often prescribed for some of their second-line usages. So they are appropriate for short-term use, which can be thought of as being around 1 to 3 days, for prolonged sleeplessness, which is not due to circadian rhythm or chronic sleep problem. Some examples of this would be if a patient has experienced recent grief or acute stress or is having severe jet lag, it'd be appropriate to prescribe a benzodiazepine to be used for a few days. They're also appropriate in the setting of severe and acute anxiety, where no other appropriate support is immediately available, while waiting for counseling or therapy support to be arranged, as well as while waiting for therapeutic onset of other first-line pharmacotherapy for anxiety, such as our antidepressants. They can be used in certain treatment-resistant intractable seizure disorders, and in this case, what is approved is clonazepam or clobazam. And diazepam can be used for severe and acute muscle spasms that haven't responded to the first-line treatments. Of note, there is only very low-quality evidence about using them in the setting of tardive dyskinesia, and a 2018 Cochrane review determined that there were only a few small and poorly reported trials on the effect of benzodiazepines as an adjunctive treatment for antipsychotic-induced tardive dyskinesia. They found that overall, these inconclusive results meant routine clinical use is not indicated, and that treatment using benzodiazepines for tardive dyskinesia remains experimental. When thinking about selecting benzodiazepines, I would urge you to consider trying to avoid the use of alprazolam, as we've learned more about its unique pharmacology. We know that it's the shortest acting with a half-life of 6 to 12 hours. It's very potent. 0.5 milligrams is equal to 5 to 10 milligrams of diazepam, depending on an individual's cross-tolerance. There's also increased risk of tolerance and interdose withdrawal and rebound symptoms because of how short-acting alprazolam is, and it is more toxic in overdose, especially when combined with other substances such as opioids. It is also more reinforcing and therefore has a higher risk of misuse and addiction than the other benzodiazepines. The reason that alprazolam is more reinforcing and therefore has a greater risk of misuse and addiction is because it causes a significant increase in extracellular dopamine in the striatum, and this is therefore more reinforcing and more likely to lead to misuse and addiction. This increase in the extracellular dopamine is not seen with lorazepam. When I need to use a shorter acting benzodiazepine, I will preferentially choose lorazepam over alprazolam for the above reasons. I would also urge caution with the use of clonazepam. Similar to alprazolam, it is more potent, and 0.5 milligrams is equivalent to approximately 5 to 10 milligrams of diazepam. One of the bigger limitations I come up against is when someone has been on clonazepam chronically and we're tapering, your taper becomes limited by the dosages that it is available in unless you start to use other methods or compounding pharmacy. So the smallest dose that the regular size tab comes in is 0.5 milligrams in the US, and it does come in a 0.25 milligram and 0.125 milligram oral disintegrating tab. However, it's variable whether insurance covers this, and it can be difficult to cut it in much more than half because it becomes crumbly. We've also seen that for many, withdrawal from these more higher potency benzodiazepines is more difficult. The higher potency benzodiazepines are also the ones most commonly prescribed: alprazolam, clonazepam, and lorazepam. When thinking about the efficacy of benzodiazepines in anxiety disorders, benzodiazepines were superior to placebo in reducing short-term anxiety symptoms, which is certainly not a surprise to most of us. However, we should keep in mind that less than 2/3 of patients experience full remission of their symptoms with this treatment. And so, like many of our other treatments, it requires a multimodal approach. Additionally, anxiety often returns when treatment is discontinued, and sometimes is worse because of withdrawal or between dose withdrawal. For insomnia, it's been found that benzodiazepines can help induce sleep in about 50% of patients. However, this therapeutic benefit is often short-lived, about 1 to 2 weeks. After that time, it may be hard to tell whether a patient is getting the benefit of sleep from the medication, or whether if they don't take the medication and can't sleep, it's because they're experiencing rebound from withdrawing the medication. Additionally, it's important that we and our patients understand that benzodiazepines reduce the amount of time that is spent in restorative stage 3 and 4 sleep, and also reduce REM sleep. This is similar to the effects of alcohol on sleep. So to review the key points for this video, benzodiazepines have several first-line indications for use, including the treatment of alcohol and benzodiazepine withdrawal, acute crisis anxiety without psychosis, acute movement disorders including catatonia, REM sleep behavior disorder, status epilepticus, and procedural anesthesia. Second-line indications include acute insomnia, as well as severe and acute anxiety. Finally, it's important we always use the lowest effective dose for the shortest duration, and that we educate patients that over time, if they take this on a regular basis, they will likely experience decreased efficacy as they develop tolerance to many of the common effects.